start the recording? Okay, we got that. And for those of you who don't know me, I do see that some names I haven't recognized before. So there may be people who don't know me. I'm Ria Markowitz, and I'm part of the Teledermatology in rural Georgia program at the Georgia Cancer Center, and I'm part of the Hub team. Dr. Kendall Buchanan and I will be serving as co-facilitators of the TeleECHO session today. So I'm going to say that I have been under the weather for several days, so I'm logging in from home, which means that my furry friend may be bothering me. This is the time of day when my dog usually wants a treat or something. So hopefully she won't start barking, and hopefully I will not lose my voice, but will be able to carry on with today's presentation. So at this time, I hope everybody, most people have their screens on gallery view with their cameras going so we can see each other. And I would like to welcome our TeleDerm clinic healthcare providers. We have the following clinics are represented: East Georgia Healthcare Centers at Mount Vernon, Soperton, Evans Health and Wellness, Baxley, Metter, Sylvania, Wadley, Swainsboro, and the Phoebe Family Medicine Residency Program. And I want to welcome members of our TeleDerm team. We have our dermatologists, Dr. Davis, Dr. Rabinovitz, Dr. Buchanan. We have derm residents and medical students. And then handling our controls and keeping the show going is Brenda Santiano and Kenza Mamuni here at our hub. So we have a chat going, and please remember to put in your, enter into the chat your full name, your email address, the clinic where you are, and what your affiliation is. And there are already examples in the chat. And so we can now I can review today's agenda with you. If we can have the next slide. Brenda? Or I'm not controlling the slides.
There is the agenda. You cannot see the screen, the agenda?
I see the first slide, the welcome slide.
I think no, we are now in the agenda slide.
Do other people see the agenda slide?
No.
No. Let me see.
You have to be on the presentation mode.
We're at the presenter view.
Yeah.
Aha. And do you want to put it into slide view, slideshow?
There is, you can see it or not.
Anyway, the agenda for today is we start with introductions as usual. Our didactic presentation will be by Dr. Harold Rabinovitz, and he will be talking about the aging population, normal versus abnormal, and that is something that some of us in particular are very, very interested in. And then we'll have a case presentation by Rushan Momin, our third-year medical student, and then we'll have a discussion, wrap up, and announcements. And oh dear. And now I'm going to introduce Dr. Kendall Buchanan, who will take over today's session. Dr. Buchanan's a member of our Department of Dermatology and practices at AU's Care Center for Dermatology in Aiken. So this is very timely. Take it away, Dr. Buchanan.
Thank you, Rhea. We can go on to the next slide. So we will start with a few announcements. You know, this is kind of our basic goal of Project Echo is to move knowledge instead of people. Next slide. And so we're going to try to do this at the local level and use all the distance learning approaches as you guys have been sending me, all these amazing consults to really dissolve the dermatologic health disparities that we face with our patients living in rural areas. Next slide. And so these are a few general reminders. All of these sessions are recorded. By participating in these sessions, you are giving us your consent to be recorded. Please do not mention any PHI in these discussions. And if you have any questions, you can feel free to send us an email. Next slide. Next slide. So just a few reminders. Try to keep your video on. I know it can be a lot at times, but we really do want to see everyone's faces. If you have any questions, specifically today in our presentation by Rushan, there's going to be interactive questions. So we really encourage you guys to participate in the chat. And if you do have a specific question, you can raise the electronic hand and just introduce yourself before you speak. And I think that's it. So with that being said, we can go to the next slide. It is my pleasure to introduce Dr. Rabinovitz. He has been an amazing mentor to me, as well as our whole department for the last 3 years now. And so he is going to be talking about the aging skin.
Kendall, thank you very much. Let me put my lecture up. And we'll get started. So as Kendall mentioned, my topic is on the aging skin. As a disclosure, I'm either a clinical investigator, speaker, or consultant for these various imaging companies. All cartoons are non-copyrighted and taken from Bing.com Create. It's estimated in 2022, there were approximately 40 million individuals over the age of 65. By 2050, that'll be over 80 million. So it's important to understand a little bit about skin aging. It's a natural phenomenon. It's defined as changes to the skin that occur due to aging. Here you see young skin and old skin. Young skin is characterized by smooth texture, no sagging, good elasticity, good collagen and subcutaneous tissue, as well as an even color. In contrast, old skin is characterized by wrinkles, sagging, hollow cheeks, uneven color, and skin growths. The aging process is a continuum, and you can see the changes very subtly over time. Here we have two 70-year-old men. One looks like he's 35, not a wrinkle, smooth skin, whereas the other individual you can see has wrinkles, hollow cheeks. And what is this difference in aging due to? Well, there are two etiologies. There is intrinsic aging and extrinsic aging. Intrinsic aging is genetic. It's inevitable, and it's due to the passage of time. Intrinsic aging is a slow process with clinical features where normally the skin is a little pale, a little less static skin. You then develop fine wrinkles, and as time goes on, these wrinkles become more apparent. Histologically, we do see changes as well. We see changes in both the epidermis and dermis where the skin becomes thinner. You have a reduced number of fibroblasts, less collagen, and more matrix. And there are structural alterations at the D junction as well, where it contributes to the increased skin fragility and the reduced nutrient transfer between the dermal and epidermal layers. Here on the left, we have normal epidermis and young skin, and here we have old skin. And you can see you've lost what are called the retae. The elastic fibers unravel, the collagen becomes thicker.
Okay.
Young skin and old skin. What are the factors in intrinsic aging? Well, there's alterations in cellular metabolism, there's gene background, as well as hormonal factors. Alterations in cellular metabolism, these changes are partly the result of the cumulus endogenous damage due to the continued formation of reactive oxygen species known as ROS, which are generated by the oxidative cellular metabolism. Now, ROSs are generated after only about 15 minutes of ultraviolet light exposure. This group includes the hydroxy radicals, peroxide, superoxide radicals, and singlet oxygen. And this results in the formation of abnormal amounts of enzymes responsible for collagen and protein degradation in the extracellular matrix, apoptosis or cell death, protein and lipid modification, and proteins which contribute to tumor initiation and increase invasiveness. Gene background. Well, we know that telomeres form the ends of the human chromosomes and shorten with each round of cell division. This mechanism actually limits the proliferation of human cells to a finite number of cell divisions, and it seems that the telomeres are responsible for longevity. And finally, then we have gene background, and finally, hormonal background. So the hormonal factors, we know that the skin is a hormone-dependent organ. The decline of the secretions during menopause accelerates the skin aging. Menopause appears as a turning point in life with a decline in skin qualities. And we know that estrogen is important, encourages the extracellular matrix production, prevents decreases in collagen, skin thickness, skin hydration, and epidermal barrier function. For men, there's a reduced amount of testosterone, which also accelerates the aging process. What about extrinsic aging? Well, we have photo damage or ultraviolet light radiation, we have smoking, we have pollutants, diet, but none of these are inevitable. Skin responses to ultraviolet light, we've already spoken about ROS. Then we also have direct and indirect DNA damage. And with UVB, you have direct DNA damage. With UVA, indirect DNA damage by the free radicals. But both of these then result in mutations as well as cancer. We have keratinocyte changes, Langerhans cell changes, melanocyte changes, and dermal constituent alterations. So the keratinocyte, over time, you'll develop increased atypia. There's an increase in the apoptotic cells, the sunburned cells, and reactive thickening of the epidermis. For the Langerhans cells, these are the antigen-presenting cells. These are our skin macrophages. There's an absolute number which decreases following the ultraviolet light exposure. There's morphologic changes and a decreased response to antigens. For melanocytes, we know there's an increase in number after ultraviolet light exposure. There's increased cellular atypity, and there is haphazard distribution which occurs within the epidermis. And within the dermis, there's a decrease in the overall thickness, there's decrease in collagen, and increased deposition of irregular elastic-like material. So let's take a look at some clinical conditions seen in the elderly. The most common is xerosis, and this is characterized by dry skin, and it's quite prevalent. And it's not uncommon to have itching from dry xerotic skin. Along with atrophy of the outer layer of the skin, there's a decrease in the vascular supply, the lipid composition changes, and moisture retention is compromised as well. This often leads to scale formation, and in the absence of erythema or a specific skin eruption. Now, the management is basically to modify bathing techniques, use emollients to replace the lipid components of the skin. And we do this with various moisturizing creams, which contain urea, ceramides, lactic acid, or glycerol. And these emollients hydrate the skin and restore its outer layer. For those patients who need a prescription moisturizer, these usually contain higher percentages of urea or lactic acid. Then we have another condition which is called osteototic dermatitis. This is characterized by these pruritic, dry, cracked, polygonal fissured skin with irregular scaling. It occurs on the shins of elderly patients, and the management includes emollients and low-potency steroids, and this helps manage some of the pruritus. Senile purpura, quite common. It's also known as actinic purpura and results from the sun-induced damage to the connective tissue of the dermis. It's combined with the fact that the vessels become thinner, fragile, and collagen decreases with increasing age. And it's characterized by these ecchymotic areas. These usually tend to resolve within 1 to 3 weeks. Sometimes you'll get some areas where you'll have residual hemosiderosis or post-inflammatory hyperpigmentation in the affected areas that occur. These ecchymotic areas sometimes cause cosmetic concerns, and sometimes there is permanent changes, but there's no scarring, and the lesions are not associated with any serious conditions. These are all the ways that different individuals in the literature, in terms of the management, in my opinion, none of these work. We recommend for our patients to use skin sleeves to the arms and legs, particularly when it becomes a problem and you have this continuous bruising. You know, many of these patients are on anticoagulants as well. Guttate hypomelanosis. Guttate actually means dewdrop, and these idiopathic lesions is characterized as diffuse hypopigmented macules or white spots. The size of the lesions are most commonly about 1 to 3 millimeters. We see these with individuals with Fitzpatrick 1 and 2 skin, and it's seen in these individuals where it's related to the cumulative sun exposure and age. The white spots are actually due to a decrease in melanin in the skin. Now, the predominant areas are on the arms and legs, very, very commonly seen on the anterior portion of the legs. The management is basically sunscreens, skin tears, skin fragility, and scarring. So a skin tear is a wound that occurs when the layers of skin separate or peel back. It can be due to trauma, bumping, dressing changes. Most often happens on the arms and legs, and there are 3 different types. Type 1 is a linear tear, where the flap can be repositioned to cover the wound bed. The type 2 is when there's partial loss of the flap, and it can't be repositioned to cover the whole of the wound bed. And type 3 is when the flap is totally lost and expires the wound bed. The management is gently clean the wound with warm, clean water, pat dry with a clean towel. If a skin flap is attached, try to replace it by rolling it back over the wound. Petrolatum jelly, Aquaphor can be applied. You clean the wound with a clean non-stick pad. We use sleeves for arms and legs, skin guards, and hydrate the skin. Here are some examples of pictures that I actually just took last week of patients, and you can see the dry skin, some of it's mottled. Here we have a solar lentigo, some fine scale. And this 76-year-old man, he has osteototic dermatitis. You can see he has diffuse scaling, post-inflammatory hyperpigmentation, in addition varicosities, and perhaps the beginnings of an early skin cancer. This gentleman here, you can see he has purpuric lesions. You can see he has a solar lentigo, and you can see the varicose veins as well. More examples, just showing you these purpuric areas. Solar lentiginous as they evolve into early seborrheic keratoses. This is a patient who's on anticoagulants, has a skin cancer here. He's bled into the skin with the purpuric areas, and notice the discoloration of his skin. He has some keratotic papules as well. Some of these are what we call stucco keratoses. And another individual with the same type of problem, with bruising and bleeding into the skin, perhaps some early areas of actinically damaged skin with some actinic keratoses. Solar lentigines and seborrheic keratoses. These are the most common acquired benign tumors. Here you can see this flat pigmented lesion a lentigo. When it becomes raised, it's a early seborrheic keratosis, and a solar lentigo evolves often into a seborrheic keratosis. The frequency. By the time you're 75 years old, almost 99% of individuals will have either a lentigo or a seborrheic keratosis. A lentigo evolves into a seborrheic keratosis, and this is a full-fledged seborrheic keratosis, very well circumscribed and raised. The other process is a lentigo or a seborrheic keratosis can undergo regression. And when a lentigo or a seborrheic keratosis undergoes regression, we call it a lichen planus-like keratosis. And this is the dermoscopy features. Very often they can simulate melanoma. And here we have one of my patients just from last week, just showing you the plethora of seborrheic keratoses he has on his back. Melanoma on sun-damaged skin. Here we have 3 lesions, a lentigo, a seborrheic keratosis, and a melanoma on sun-damaged skin. And the differential of an isolated pigmented lesion includes these 3, as well as pigmented actinic keratosis. So if you have an isolated pigmented lesion, please send those to Dr. Buchanan to do dermoscopy, because dermoscopy can evaluate a lentigo and distinguish it from a seborrheic keratosis, as well as a melanoma on sun-damaged skin. And here we can see the pattern dermoscopically. These fine lines, slightly curved, moth-eaten borders, that's a lentigo. And with dermoscopy, a seborrheic keratosis has these early ridge formation and a different pattern that one sees with melanoma on sun-damaged skin, where you have some gray dots granules, which are regression structures, and other features as well to help us distinguish from a lentigo and a seborrheic keratosis. So when you have an isolated lesion, send those to Dr. Buchanan, because dermoscopy makes the difference. So I'm going to show you examples of facial melanomas. This is a melanoma. Almost all facial melanomas on sun-damaged skin are isolated to a particular quadrant, where sometimes it's the only lesion on that patient's face. Isolated lesion. Isolated lesion, nothing else on the forehead. Isolated lesion on the ear, nothing else on this gentleman's face. Isolated lesion. Isolated lesion. And then we have actinic keratoses. These are proliferation of atypical keratinocytes induced by ultraviolet light, quite commonly seen on the face and on the sun-exposed areas, particularly the arms and the legs. They're characterized by these dry, scaly, rough-textured patches or papules seen on these sun-exposed areas. Now, approximately 10% of actinic keratoses are associated with a squamous cell carcinoma, and therefore we treat them. And these are all the different ways that we manage an actinic keratosis with broad-spectrum sunscreens. Nicotinamide or niacinamide, 500 milligrams twice a day, reduces the precancers by about 20%. Another way we manage these is with some of the topical creams, 5-fluorouracil. We use it twice a day for 2 weeks. And when I first started practice, we used to use 5-fluorouracil for 4 to 6 weeks. Patients would run out of our offices very, very quickly because you don't want to be inflamed for that period of time. And about 20 years ago, we realized using 5-fluorouracil twice a day for 2 weeks did the same thing. But the new paradigm is using 5-fluorouracil and calcipotriene, which is a vitamin D analog used for psoriasis. Now we can use it for 5 days as opposed to 4 weeks or as opposed to 2 weeks with the same clinical response. And then we have imiquimod. We use this daily for 2 weeks, and you'll get a good response with imiquimod. For polypodium leukotomas, this is actually a plant extract which we recommend for patients, gives individuals an additional SPF of about a 5 within the plant extract. Photodynamic therapy, or PDT, which is a psoralen, which is applied to the skin. It's activated by ultraviolet light, is very, very useful in managing actinic keratoses. And then cryosurgery, which has been the mainstay, although the overall response rate with cryosurgery is really only about 30 to 40%. So this was one of my patients who had an extensive squamous cell carcinoma, who had Mohs surgery. He has also had chemotherapy, and this is his baseline. He has actinics, but this is a good baseline for this gentleman. And you can see these extensive actinics and perhaps maybe some early superficial squamous cells. This is his baseline. We can't get him better than this. So we see him quite frequently for follow-up visits. Here we have a small lesion on the nose. There's a little scale. Dermoscopically, it is a distinct pattern characterized by these white projections in these 4 white points, which we call rosettes. And this was the use of the combination of the creams. And this is about 4 weeks after using the medications. So I hope you'll see that these do need to be treated. These actinic keratoses evolve into significant squamous cell carcinomas if left untreated. Thank you for your attention.
Thank you, Dr. Rabinovitz. That was great. I'm just going to look in the chat and see if we have any questions. Okay. If anybody has any questions at this time, you can feel free to raise your hand. If not, we'll go ahead and move along to our case presentation. Awesome. Well, I would like to introduce Rushan Momin. She is a third-year medical student with us at the Medical College of Georgia and Augusta University. And she is going to be doing a case today that is right along the lines of all the entities that Dr. Rabinovitz was speaking of in regards to isolated pigmented lesions. So, as I mentioned in the beginning, we are doing this a little bit differently. There's going to be a case and some questions within the case. And so I would like for you guys to try to participate by typing your response in the chat. So, Rushan, if you want to go ahead and share your slides.
Yes, thank you. Can you guys see my screen?
Yes.
Okay. So, hi everyone, I'm Rushan. Thank you, Dr. Buchanan and Dr. Rabinovitz for presenting. Today we're presenting on an 82-year-old male who came in with a pigmented lesion to his left cheek. He's had this treated with liquid nitrogen in August of 2018 for 2 cycles, and he doesn't like the way it looks. So he came in to get it frozen off again today. He has had basal cell carcinoma twice before. So here's a closer look, and we can see it's an isolated pigmented lesion, and there's like minimal surrounding sun damage. And so for our differential, solar lentigo is at the top because of the well-defined borders and the scalloped edges, and it's kind of uniform in color. There's also a melanoma due to the isolated nature of the lesion. Like Dr. Rabinovitz mentioned earlier, if anything's isolated, we really do want to take a closer look. It could also be a nevus. It's usually unusual to see a dysplastic nevus on the face, but this one, it could be a benign one. Also pigmented actinic keratoses if there were more background sun damage, which we aren't really seeing here. and then lichen planus-like keratoses, which you would see with a more diffuse gray color rather than the brown that we're seeing here. And so the biggest question here is it benign or malignant? So I've kind of separated the differential up into those two categories. And so here, if you could decide what you think the most appropriate next step would be and type your answers in the chat.
If you can't see Rushan, I'll just tell you everybody's going for C.
Okay, perfect. So that is what we're doing. We would evaluate with dermoscopy, and that's because we at this time are unsure of whether it's a benign lesion or malignant lesion. So we couldn't treat it with liquid nitrogen. That would be us assuming it's a benign lesion. And topical chemotherapy cream would be along the same lines of us thinking that this is a pigmented actinic keratoses, which we don't know until we've taken a closer look. Same with the bleaching cream, it would be inappropriate until we've ruled out a malignancy. So here I have some closer images from dermoscopy, and you can take a look at these areas that we've highlighted here. This one is a polarized image. This one's polarized as well, and you can see this area that we've pointed out here. And then we've got some non-polarized images, so there's a color difference. You can see this area here and this area here. One more non-polarized image. So if you could put in the chat which dermoscopic features you were able to see.
So this one's a little tricky. Rushan, do you want to go back to maybe like the second photo?
Yeah. There we go.
Or sorry, the one before that. So where that circle is, I want you guys to really kind of look at that. And now we can go back to the question.
And here we go.
It looks like we have a B
Mhm.
from Michael B. Awesome.
Awesome.
Yeah.
So yeah, so we're seeing these focal gray dots that form angulated lines. We're not seeing the milia-like cysts. I'll go back so we can see the images we've put in. The white to yellow kind of clouds weren't present in the pictures we looked at. We didn't see this fine parallel printing pattern or any scale really in any of the pictures. And then didn't see this reticular network either. So I've just got that written here. And so, like we mentioned, none of these features were present, but what we did see were those angulated lines that I've kind of drawn in here for you to take a look at. And they're just there we go. And so here we can see the granular pattern and the lines. And this image right here at the top shows the progression of how a melanoma may progress over time with the different angulated lesions and lines and colors. And then here we can see we have some of the follicular openings with a little bit of granularity around it. And then in the non-polarized images, there is a difference in color, so we're able to see those gray-brown dots a little bit more easily. We would also see these in lichen planus like keratosis, but it would be more diffuse. And so back to the differential that we mentioned, I think we should take a look at some of the benign lesions and see what some of the characteristics of those are. And so here we have a solar lentigo. You see fine parallel lines and a more uniform color on a background of sun damage. And then with the benign nevus, you also see the symmetry, few colors, and these fine lines with that pseudo network. It's got a good pattern. And then with lichen planus-like keratoses, we can see just from a distance as well, it's more gray in color. And then on dermoscopy, there's these diffuse gray dots. They're focused around white to yellow follicular openings. And it's symmetrical in nature. Here we've got a pigmented actinic keratosis. The biggest thing here is we're seeing scale, and then the rosettes that Dr. Rabinovitz had mentioned around these few white openings, white projected follicular openings. So going back to you guys, if you could drop in the chat what you would like to do next for our patient.
Yeah, I think Mackenzie, great job, and Gabby
Yes.
and Emily.
So we would offer a skin biopsy or a confocal evaluation. This patient was seen with Dr. Buchanan and Aiken, so a confocal exam really wasn't easy for them since they would have to come to Augusta, and that wasn't something they wanted to do at the time. But we were able to perform a shave biopsy for them so that we could take a closer look and really confirm whether this is a benign or malignant lesion. And for all of these other options, we would really just want to take a closer look before we reassured them or scheduled them for a follow-up. And so we got the histopathology report, and it showed that it was a melanoma in situ lentigo maligna type. And so for the plan for this patient, we were able to do Mohs micrographic surgery, and here's what they look like after with the suture. And we were following them up every quarter for 3 months, every 3 months. And so overall, to summarize, isolated pigmented lesions generally need further evaluation. You can tell a lot from a distance, but dermoscopy is a tool that can help you when there are challenging lesions on the face. Certain characteristics such as scale or varying colors, symmetry, and then whether it's on a background of sun damage can help you narrow your differential one way or the other. We have plenty of resources, including the Derm Engine consult platform, and then you can always refer your patients to a dermatologist or for a confocal evaluation if you need a closer look. And that's all.
Thank you.
Thank you.
Great. So we tried something different this time. Thought it would be fun to be a little bit more interactive. Does anyone have any questions for Rushan or Dr. Rabinovitz? And
I'd like to
go
make
ahead,
this one
Dr.
comment.
Rabinovitz.
So for those who don't know what the confocal microscope is, it's actually a laser beam which when hits the skin gets reflected back into a computer screen where you see the layers of the skin live. It's like virtual pathology. So you can actually see at the cellular detail no different than a pathologist. When a pathologist reviews a slide, he's looking at approximately 2% of the lesion. With confocal microscopy, you're looking at 100% of the lesion in a horizontal plane. And it's really the Rolls Royce in terms of for diagnostic purposes. And there is one in Augusta, which is quite useful. For this type of lesion, though, sometimes it's hard for patients to travel. And based just on dermoscopy, you were going to biopsy it anyway.
Mhm.
And that's the rationale for doing these biopsies, is to confirm the diagnosis and then the ultimate treatment, in this case with Mohs surgery with immunostains.
Yes, and these are the type of patients that, I would be happy to look at through the consult platform. As I mentioned last time, we really place a lot of value in being able to take a really good clinical image and a really good dermoscopy image. And it is challenging at times, especially when you're busy in clinic and you maybe don't have time to look at the photos until after clinic, but I can provide the most value to you if I'm able to get a consult that has the best quality clinical and dermoscopic image. And so that requires, a clean camera lens, a clean mole scope, the use of alcohol or gel. And once those things are done, the consult can be submitted, and we can make some progress in that way. But I know it's frustrating on both ends when I have a consult that's a little bit blurry or scaly, and it's really hard to make a diagnosis. And often you guys may have to call the patients back, and so in the end, we're not really doing the best that we can. And so, if you guys have any questions about how to take these photos with the mole scope specifically, we were showing today polarized and non-polarized image. The mole scope has just one image. You can only send me a polarized image. So there's no like toggling back and forth with that. That's the only image that it will take. So, and that's fine for what we're doing now. But if you can remember that, I think all of our patients would be really appreciative. Does anyone have any questions about the consult platform? Or I know we had some questions last time. Brenda, we may have time today if we want to bring some of those up. I think I lost the chat that you sent me. I think one of the questions.
I can post here each question. Here is the first one that came from Kelly Kennedy from Swainsboro.
Kyle. Okay.
Kyle.
Is he? I think. Oh, Kyle, if you're still on, I know you had quite a few questions from last session. Do you want to ask your questions? I don't want to put you on the spot, but
I'm trying. Well, we got to do a little extra training, I don't know, maybe last week about how to use the scope and stuff, and that helped a lot.
good.
And I think my second picture was a lot better than the first one. So
Yeah, and I think you had a question about, because last week we had a case on pigmented basal cell carcinoma, and I think your question was, do as dermatologists, do we prefer that you do a biopsy in that situation or refer to a dermatologist? And I think that kind of depends on your own comfort level. And we really, in general, when you guys submit these consults, typically we have a good idea of kind of what category that lesion is going to fall into. So you can also use the feedback from the consults to sort of guide if you feel comfortable doing a biopsy, especially if it's on facial skin. If you have all the tools you need in your clinic, I think most dermatologists would be comfortable with that. But certainly if you would feel better about referring that lesion to a dermatologist, that's something like we would be happy to see your patients in Augusta, or I'm sure any local dermatologist would be happy to see those patients as well, because with anything, you know, if you don't have the proper setup and if it's going to be a stress and a burden to have to work in a biopsy on your already busy clinic day, you know, that's something that I can do and it'll take me, you know, 30 seconds. And so it just kind of depends on your own workflow, but like specifically where I train in Aiken, we have a lot of local primary care providers that are doing their own biopsies, and that's just because they've incorporated it into their practice over the years. And I know another question you had was sort of speaking to our platform here, if we were going to be able to provide more education in regards to, you know, doing biopsies. And that is something that I think we are working towards. I know last year we didn't feel that we had enough interest in teaching how to do biopsies and that sort of thing, but with bringing new providers on, hopefully we can get more interest in this area, and then we can certainly develop our curriculum for next year around that.
And I think my question about the biopsy in a primary care, a lot of times these patients they come in so late. So my concern is always how invasive is that skin cancer? And I've had some dermatologists in the past say, no, no, don't touch it. I don't want you to touch it because of how invasive it could be. And so that was my hesitancy with doing the biopsy, especially on the face more so.
Yeah, and I can definitely understand that, you know, and part of that is your relationship with your local dermatologist and your comfort level, as well as your patients as well. But, you know, you can use us for our resources. You know, I absolutely love you guys sending these consults in. It's so easy for me. I think we just calculated the average time to respond to the consults was around 25 minutes. And I understand that most of your patients may still be gone by then, but I do try to get to you guys as soon as I absolutely can so that it can help ease this decision-making process for you. So, and you know, you can always email me or Dr. Rabinovitz or any of the providers here. We would be happy to help you any way we can. But we really appreciate all the consults you guys have been sending in. And well, I know specifically the platform that we're using is also working to incorporate artificial intelligence into the image capture process so that when you take these images, it'll automatically kick it back and not let you submit the consult if it's a blurry image, because sometimes it is hard to tell. So that's, I think, in the works at some point. Okay, Rhea, I think I've talked enough.
Okay. Well, I want to thank Dr. Rabinovitz for an excellent presentation about a subject that I'm familiar with as the patient, and Rushan for your great case presentation. So let's see, our next session will be April 1st, April Fool's Day. And the didactic presentation will be by our very own Dr. Loretta Davis, Chair of Dermatology. And she will be talking about the intertriginous skin, something else I'm familiar with. And then we'll have a case presentation by Gabriella Duquesne, MCG medical student. Gabby has been very active in the teledermatology project. And so she will be presenting that. And the CME code for today is 27766. Make sure you get that. You'll receive it in an email as well. And make sure you take care of that quickly before the time runs out. And remember that you must be registered with the MCG CME before you can send that text. To the clinics, keep sending your your consults to Dr. Buchanan. I think she spoke about that a lot. And again, thank you to the speakers. And I hope everyone has a good rest of their day and evening.
Rhea,
And- yes. Who
hey,
was-
I just texted that code and it's telling me that the activity ID is no longer active. Just letting y'all know.
Yeah, sorry, there is a mistake with the code. It's 22766. I'm gonna put it on the chat.
That worked.
Yeah.
So, Ken, so what is it? Are you putting it in the?
Yes.
Oh, 22766. Everyone got that? Okay, thank you. Was that Lynn who pointed it out? The mistake, whoever?
You know I'm verbal.
Yeah, I know you're verbal. Thank you for pointing that out, though. So that's very good. So if there's no other verbal announcements, all of our guests can sign off. And a reminder for our TeleDerm, the hub team, to stay on for a couple minutes. Thanks for attending.